I now want to move on to the methodology, the way that ECT was given in this case. First of all, is that based upon the presentation of the individual patient? What a practitioner chooses to give in terms of, and I'll discuss it with you, energy, unilateral versus bilateral, caffeine, that type of thing. What's that based on?
It is always an individualized decision about how to administer ECT in a specific patient, yet generally it falls within fairly standard guidelines about how you might proceed.
Okay. And is that up to the judgment of the practitioner?
Always, yes. And the ECT provider, in collaboration with the anesthesiologist in terms of which medications you're going to use for the procedure.
Okay. Doctor, is there an exact algorithm? And what I mean by that is, can you put in this amount of depression, this age, this sex, this ethnicity, and spit out, aha, here's how you give ECT?
No. I mean, this is why we do the research we do. We're trying to develop better predictive models for which treatments work in which people. There are general algorithms that are guidelines, not requirements. But no, each individual patient is an individual patient, and that's a very specific, individualized treatment decision that the psychiatrist, in conjunction with the patient, has to make.
So, based on the individual and the practitioner's best clinical judgment. Is that fair?
Correct.
Okay. Let's discuss, first of all, bilateral versus unilateral. Can you discuss with the jury the relative pros and cons of each?
Right, so bilateral ECT is where you're providing ECT at one electrode on each side of the head. That was the classic ECT for most of the history of ECT. That's how it was administered, was bilaterally. More recently, groups have been studying right unilateral ECT, where the initial stimulation is only provided to the right hemisphere of the brain, rather than both hemispheres of the brain, with the presumption supported by some literature that it may have fewer of those short-term cognitive side effects associated with it.
Hang on. I'm sustained Dr. We just don't refer to the literature.
Oh, sorry. Apologies. So even literature in general? Okay. So the advantages of bilateral ECT are that it's more effective. It actually works more quickly. And many patients that don't respond to right unilateral ECT will actually respond to bilateral ECT. The advantages of right unilateral ECT is that it has fewer of the short-term cognitive side effects, but it may be less effective and it may take more treatments to be fully effective.
Okay. Bilateral. It works quicker. What do you mean by that?
So the studies, when you look at...
Based upon your education, training, and experience.
Clinical experience, bilateral ECT may be effective in 5 or 6 treatments on average, whereas right unilateral ECT may be effective in 8 or 9 treatments. So it's not necessarily a big difference, but there is documentation. In my own experience, there's reason to believe bilateral is faster than unilateral ECT.
You also mentioned that it's more effective. What do you mean by that, based upon your education, training, and experience?
Again, bilateral ECT is considered by me and my colleagues to be the most effective form of ECT, as demonstrated by the fact, clinically, that if somebody doesn't get better with right unilateral ECT, they are likely to get better with bilateral ECT.
And in someone with severe depression, like we've discussed, like Dr. Dadi, is bilateral appropriate? As long as you discuss the risks and complications, unilateral versus bilateral?
Yes, and there are many cases in my own experience where I absolutely recommended bilateral ECT to start with because of the severity of the depression and the desire to have a more rapid response.
Okay. You also mentioned the potential for more, I think you discussed, short-term side effects with bilateral. Can you tell the jury what you mean by that?
So again, one of the side effects with ECT are the short-term memory loss, confusion that happen typically only during the course of ECT. It can be more or less severe in a patient. That depends on the patient, but it also depends on treatment parameters. So bilateral ECT in some patients does lead to more of those short-term memory problems than right unilateral ECT.
And when you say short-term, so the jury understands, are we talking about 6 years of memory issues, 3 years, 6 months, or a matter of days or weeks?
No, so again, and as we discussed before, the cognitive side effects of ECT are generally limited to the time that you're actually giving ECT and maybe a week or two beyond the last ECT treatment. When I say short term, I'm referring to that period of time. Recognizing that when patients have memory issues with ECT, they'll often resolve between treatments. So they may find that they're having memory problems the day of ECT, but the next day they're doing perfectly fine.
Okay. You've read the deposition of Dr. Sharma, correct? And you're aware that he discussed with his patient, Dr. Dadi, the relative risks and benefits of short-term versus long-term, correct?
Correct, yes.
Was that appropriate?
It seemed to be.
Within the standard of care?
Absolutely.
Was the suggestion or the option to Dr. Dadi of bilateral versus unilateral within the standard of care?
Yes.
Okay.